pelvic inflammatory disease, or PID, from the gynecology section, a sexually active 14-year-old girl is brought to the emergency department because of acute bilateral lower quadrant abdominal pain. She has a history of multiple sexual partners. Her temperature is 102 degrees Fahrenheit or 38.9 degrees Celsius. Bimanual pelvic exam shows cervical exudate and tenderness on cervical motion. Her beta-HCG is within normal limits. Sonogram shows thickened fallopian tubes with fluid in the posterior cul-de-sac. This patient was diagnosed with pelvic inflammatory disease. Now let's get into the episode. As a quick introduction, in terms of clinical definition, pelvic inflammatory disease is an infection of the upper female genital tract that is often polymicrobial. It may include endometritis, salpingitis, tubo-ovarian abscess, and or pelvic peritonitis. With respect to epidemiology, the U.S. incidence of pelvic inflammatory disease is 750,000 cases annually. As far as demographics, this is typically seen in sexually active women between 15 to 29 years of age. The location of pathobiology, pelvic inflammatory disease is usually polymicrobial, and the likely microbes include Neisseria gonorrhea, Chlamydia trachomatis, anaerobes, gram-negative rods, Streptococcus agalactiae, Gardnerella vaginalis, Haemophilus influenza, cytomegalovirus, and Mycoplasma genitalium. In terms of pathoanatomy, pelvic inflammatory disease is secondary to an ascending infection of microbes from the endocervix to the upper genital tract. Moving on to the presentation, as far as symptoms, these patients may be asymptomatic if subclinical. However, primary symptoms include lower abdominal or pelvic pain, chills, dyspareunia, dysuria, as well as nausea or vomiting. On physical exam, inspection may reveal fever, abnormal cervical discharge or bleeding, cervical friability, abnormal vaginal odor, ecchymosis and swelling, diffuse tenderness, and right upper quadrant tenderness, which may reveal that the perihepatic space may be involved. Provocative tests include cervical motion tenderness, also known as a chandelier test. Other provocative tests include adnexal tenderness and uterine tenderness. Moving on to imaging, ultrasonography is indicated if a diagnosis is uncertain with physical exam and clinical history. The view will be transvaginal, and findings can include thickened, fluid-filled tubes, with or without free pelvic fluid, and with or without tubo-ovarian abscess. As far as studies to obtain in the workup of pelvic inflammatory disease, labs may test positive for sexually transmitted diseases like Neisseria gonorrhea and or Chlamydia trachomatis. In terms of diagnostic criteria, positive physical exam findings include uterine tenderness, adnexal tenderness, and cervical motion tenderness. The differential diagnosis for pelvic inflammatory disease includes ectopic pregnancy and appendicitis. The differentiating factors between ectopic pregnancy and pelvic inflammatory disease is that in ectopic pregnancy, you will have a positive pregnancy test. The differentiating factors between appendicitis and pelvic inflammatory disease is that pelvic inflammatory disease typically presents with bilateral abdominal tenderness. Treatment of pelvic inflammatory disease is typically medical. This can include ceftriaxone plus doxycycline as an outpatient, which is indicated when there are clinical findings of pelvic inflammatory disease alone, which is often enough to indicate treatment of pelvic inflammatory disease. Other indications for ceftriaxone plus doxycycline as an outpatient include uncomplicated pelvic inflammatory disease and urethritis. Cefoxitin plus doxycycline as indications for intravenous medication or hospitalization is for uncertain diagnosis, tubo-ovarian abscess, or failure to respond to outpatient treatment within 72 hours. Finally, clindamycin plus gentamicin is the most potent option for unstable patients and treatment-resistant infections, for example in the setting of tubo-ovarian abscess with hemodynamic instability. Finally, let's end this review session talking about some complications, and the ones to know include infertility, ectopic pregnancy, and Fitzhugh-Curtis syndrome. So in terms of infertility, this can be seen in 15% of patients after one episode of pelvic inflammatory disease. In terms of ectopic pregnancy, there is a 10 times risk after pelvic inflammatory disease. Finally, in terms of Fitzhugh-Curtis syndrome, the clinical definition of this is infection of the liver capsule with multiple peritoneal adhesions. This has an incidence of 10% of women with pelvic inflammatory disease.